This talk is on the complaints and history of carpal tunnel syndrome. Carpal tunnel syndrome has a classic history, and if we can put the components together into three pieces, it makes it a foregone conclusion you've got a diagnosis before you even look at the hand. Now, the patient will come in with various complaints. The patient may come in saying, my arm is numb. They may say, my fingers and various fingers are numb. They may not mention numbness and tingling at all. They may come in with neck and shoulder complaints. The median nerve is under pressure in the hand, but it's sensitive along its whole course. And neck and shoulder complaints will be a part of carpal tunnel syndrome complaint. Lateral epicondylitis. The patient may come in and say, I can't lift frying pans off the stove because it hurts. And that's coming from the aspect of the elbow where the muscle attachments to the lateral epicondylitis have produced a problem. What we do with the history is divided into three parts. There's a nighttime component, a morning component, and a daytime component. Now, the nighttime component is when the patient has symptoms when they sleep or are significantly at rest. These can happen on a long car ride or even watching television. And what you have is a retinaculum right here, which is the roof of the tunnel. And the roof of the tunnel is a part of the basic part of the problem as it thickens and produces pressure in the tunnel. I'm going to bend their hand over and let this represent the retinaculum of my hand. So this retinaculum is the flexor retinaculum across my right hand. The median nerve lies on its posterior surface. It's the most volar or palmar structure in the carpal tunnel. And if that's the median nerve, the tendons, 9 of them, 9 tendons lie behind this nerve. And if the wrist is in flexion, then these tendons with the tone of the forearm muscles is bending the nerve over this flexor retinaculum. And it's that fetal position, which we all assume when we sleep, that's the basic culprit. When we sleep, we go fetal. And that produces the kinking, if you will, or the pressure on the median nerve. And the symptoms are from the ischemia of the nerve. The nerve loses its blood supply in that central portion, and it goes out. And ischemic pain is a very primitive pain in the human body, and it hurts both in the nerve plus the loss of sensation. So these patients will wake in the middle of the night, and the hand will be numb. They will lie face down, hang the arm over the bed and shake it, or get up and walk around. The patient may often tell you that the carpal tunnel doesn't wake them at night, but if you ask them, they wake up to go to the bathroom, and yes, my hand is numb. So the nighttime component is secondary to flexion of the wrist, the fetal position, the bending and pressure of the nerve by the tendons, and it can be helped a great deal by putting the wrist in extension. If the wrist is in extension, the nerve, which is lying just behind the retinaculum, is now relieved. The pressure of the tendons is no longer on it. The patient sleeps through the night, and sometimes just night splints will let a carpal tunnel syndrome quiet down. Number 2, the morning component. Very important because it is not nerve. And what you ask the patient is, when you first wake up in the morning, can you open and close your hand right away? And some people will say, it takes me about 3 pulls. I notice it, but about 3 pumps and I can be full closed, full open. Some will say, you know, it's not until 2 hours later or after I brush my teeth, I can make the hand work all the way. What happens with the inability to open and close initially is that this flexor retinaculum across the top of across the tunnel, and the nerve lies behind it, and then all of the tendons lie behind that. And this is a synovial space, and therefore these tendons are surrounded by synovium. And because the inflammation is because of a tight retinacular tunnel, there's an influence on the tendons and a synovitis. And while you sleep, water goes into the synovium and produces a mass, a synovial mass, both proximal and distal to this flexor retinaculum. And that mass of water in the synovium won't go through the tunnel. So when they wake up, you can't open and close your fingers until you pump this back, so that the gradual flexion and extension of these tendons would drive the fluid steadily back until there's now enough room for those tendons to run through the tunnel. And that's very important because it has nothing to do with the nerve. This morning component of carpal tunnel is entirely a paratendinous synovial problem based on edema. And because of that, it's a very effective confirmation that the problem lies in the hand at the base of the palm. The third component is daytime symptoms. Daytime symptoms are commonly grooming, driving a car, holding a telephone. Patients will say they have to switch sides, reading a book or newspaper. Notice that every one of these things I just mentioned are up. The hands are high. The patient is up grooming, holding a blow dryer, or reading a book or newspaper, hands on the wheel. These all are elevated. And what happens is the decreased hydrostatic pressure in the small vessels that feed the median nerve have lost some of their oomph, some of the pressure, power. And the basic problem here is ischemia of the nerve. And that ischemia of the nerve becomes worse when you decrease the hydrostatic pressure. So all of these wrist-fixed daytime activities, the ones we've mentioned so far, are secondary to elevation, but fairly classic, and you can ask them. If a patient has a job where he works over his head, a mechanic who lies on a gurney and works on the underside of a car will have great difficulty with his hands elevated. There are a couple other activities that are wrist-fixed daytime activities, and that would be anytime you hold things, a jeweler who has to flex the wrist. Now we're back into the kind of ischemia that occurs when you sleep, the fetal position. So we sort of come full circle. There is one other symptom complex I would throw in here, and that's the ulnar nerve. If there's a tardial nerve palsy, one of the nice differentiating complaints or symptoms is the ulnar nerve will have a restless arm component that the carpal tunnel almost never has. And what that means is the patient, particularly toward the end of the day, will tell you, I don't know where to put my arm. I put it on a pillow, I put it in my lap, I hang it down, I pick it up, put it on top of my husband's shoulder, and on and on. And that restless arm component is a classic for tardial nerve palsy, but not for the historic aspect of carpal tunnel syndrome.